right. We'll start. I think we can probably just go ahead and get started. We have some of our co-hosts here. We have more people trickling in. Unfortunately, we've had a spate of end of the day challenging cases that are going to hold up some of our hosts in the OR for quite some time. I'm sure pretty much everybody understands. We've all been there. I was there 2 days ago actually. So so anyway, we'll go ahead and get started. Welcome to our next session of Virtual Global Spine Conference. I'm very pleased to have Dr. Alfredo Guiroy, who joins the list of some of our esteemed colleagues who have hosted 2 sessions of Virtual Global Spine. You're one of the first you're one of the first back in the day when we first had this conference started. So it's nice to have you back. Today we're going to be discussing deformity cases, and Dr. Guiroy, I'll hand over the mic to you.
Thanks, John. Thanks everybody for having me. We're gonna discuss a couple of deformity cases today. So I will start with the first one. She's a 51 years old lady. She's an engineer. She had a diagnosis of adolescent idiopathic scoliosis 35 years ago and was treated with brace for 2 years. And she now consulted to us for progressive severe low back pain. She cannot stand longer periods than 15 minutes and had some episodes of right thigh pain, but otherwise her neurological exam was normal. Her SRS score was 3 and the ODI was 44. The DEXA scan was normal, and the you can see on her full spine x-rays a severe scoliosis with a 90 degrees lumbar and an 84 thoracic curve. And in the lateral view, it showed a thoracolumbar kyphosis 45. Her physical examination showed some trunk shift to the right, but looked pretty good balance otherwise. When you see the other test, you can see in the MRI the severe rotation with the conus medullaris in the right foramen. So that will be challenging for screw insertion. And the very healthy L5S1 disc. So for this kind of cases, we're doing now 3D model impressions to try to better understand anatomy when we're dealing with these patients. And we classify this lady using the new Lenke classification for AIS in the adults as Lenke 6. The lumbosacral curve was structural, and she's in the sagittal plane balance. So how to deal with this patient? Do you want to start, Johnny?
Yeah, absolutely. Do you think you actually go back to the X-rays, the scoliosis series?
Yeah, sure.
Okay, so we have a lady, 51, middle-aged lady who is generally pretty healthy, right? I mean, she doesn't really have any major cardiac or pulmonary or, let's say, severe osteoporosis. One of those things that need to be optimized before surgery.
Yeah.
She doesn't look obese.
Exactly.
So she looks like she's pretty much good to go. So she's got a pretty severe. She's a double major curves of thoracic and lumbar spine. As you mentioned, her Lenke classification. So, and you can see her PIL. Yeah, everything is kind of there. It looks like she's roughly within her PIL boundaries. But if you look at her main problem here is her coronal deformity and her detriment to her quality of life. So I would say she's a surgical candidate. There's no question about that. So the question is, as you said, anterior, posterior, and how high and how low you're going to go. So with her, almost certainly you're gonna have to go probably, what is that? The top of that thoracic curve is probably about T2, I think, T3, T4, something like that. So yeah, that's gonna be your UIV. Your LIV, if you're gonna extend anywhere essentially from thoracic spine down to lumbar spine, you're gonna have to go down to pelvis. So it'll be about T2, T4, something like that to pelvis. Probably would use a quad rod construct. You would have to use osteotomies. It depends how flexible she is. You could potentially get a prone full body X-ray to see how much that curve reduces when she's on the table. But you may have to incorporate some osteotomies because it looks pretty rigid. Just a bunch of PCOs as well. She looks pretty rigid. I would preferably do some sort of an inner body at 5'1", especially with these long constructs. They often have problems healing, and you can have problems with rods down the road, or sometimes they can pseudo at 5'1" junction, which is really a major problem. So I would either do a T-lift or an A-lift at 5'1". That's kind of dealer's choice as to what you're more comfortable with. I think either one is perfectly acceptable. If if she was more, if her PILL was if it was imbalanced and we wanted to get more lordosis, I would do an A-lift. But here, if you're gonna go posterior, I'd probably do it all in one shot. I'd do a T-lift at 5'1" and an instrument from T2 or T4 down to pelvis.
It's a big surgery.
It is a big surgery.
So Mike, Mike, are you there?
This is Alfredo. I'm here. I'm just driving.
Oh, sorry.
Oh no, all good. This is a tough case. I tend to agree with Jonathan. I would probably do an A-lift first because I think A-lift just gives you a better footprint at the base. And look, that's one of those areas where it is controversial. This patient is up for big surgery, but one of the reasons I like to do the A-lift first is that you can stage it. And so you can actually do that interbody work in a separate setting from your major T4 to pelvis kind of work. And other than that, I'd probably do really similar to what Jonathan suggests. You're going to need multi-level ponte osteotomies. You're going to need pelvic fixation. The big question here is whether to spare the L5 S1 disc, right? And that's something that I've tried to do in the past, and I haven't been that successful in these long constructs in patients in their 40s and 50s. Maybe in 20s and 30s, absolutely, but I found that I've been back 2 years later extending down to the pelvis on a number of cases. I've stopped at L5. When I look back at those, I go, oh, what did I do wrong? Actually, I didn't do much wrong. The disc has just become degenerate, and you're back there doing an A-lift and adding your rods down to the pelvis. So there's one reason why in these patients, if they're actually functioning pretty well, I often get them to hold off for as long as possible, and then I take them down to the pelvis rather than trying to stop at L5. But others may have a different opinion on that.
Hey, Mike, in the ones that you've stopped there and tried to spare the disc, are there any that have made it? And anything you could have picked up, like anything you think you did that helped them make it? I've left a few like that, and same experience.
Yeah, look, I think this patient is probably more likely to make it, inverted commas, than some others because their main deformity is a coronal plane deformity. I reckon those with a double deformity, sagittal and coronal, you're asking for a hiding if you try to stop at L5. I have had a couple that have made it, and I reckon when I look back with hindsight, even though I've pretty much got the balance right, and I should put some of these cases up on some of the long constructs. The other thing that can get you at that 5'1" level is we all look at the disc height, but we don't always look at the facet joints. And if the facet joints, I think, are already on the way out, then that's another sign that we should probably be incorporating that level.
Absolutely. Matt, I got a couple of questions for you. Are you using laterals for these kind of cases? Do you think it's risky with that vertebral rotation?
Yeah, look, I think I'm not sure what advantage a lateral will offer here. The A-lift for interbody support at the base, 1 or 2 levels. If I can get to 4 or 5 easily, I might slide an additional cage in there. I wouldn't probably use lateral cages here because I think that the sort of 2, 3, 3, 4 levels which you could access are not the actual apex of her deformity. I think the apex of her deformity is higher than that. And I think, you know, a lot of these older patients with old AIS curves, which is what she has, they do mobilize pretty well after a multi-level Ponte osteotomy through that apex. And, you know, high density pedicle screws, if you're worried about bone density, you can cement them in. They usually do a nice job through here. You need to also correct that thoracolumbar kyphosis that these patients get. So they get that apex, and sometimes these are tricky because the apex of your coronal deformity is not the apex of the thoracolumbar kyphosis. They get that little bit above there. So you've got a kind of a multi-planar deformity that you really have to appreciate. And the final thing is how do you adequately restore the thoracic kyphosis here? And look, for some of these really hypokyphotic thoracic spines, I use a combination of screws and sublaminar bands. And so good rod contouring, and then use sublaminar bands to kind of pull the spine up through that mid-thoracic section back to the rod, rather than overly flattening it out with a screw-based construct, a pure screw-based construct. Is my tactic for this.
You will use,
yeah,
I got it. You will use bedrock as a, in the
personally, I would use bedrock. Yeah, look, I would use bedrock because you want to fuse the SI joint in this patient. That puts a lot of load on the hips. And, you know, this patient would need to be aware in the consent process that they're at a moderate to high chance of needing a hip replacement earlier in life than what they would have otherwise. But I think spine deformity also puts a lot of pressure on the hips. And so the question remains as to how much speeding up that process. Yeah.
Yeah, is an ASD on the hips, right? Is an adjacent semi-degeneration.
Yeah.
But,
I mean, if you do a S2AI and the joint also auto fuses, or you do a bedrock and you're deliberately fusing it, I think, you know, the remaining mobile section is the hip joint. And the good thing is we have a good replacement for that. No, we don't have a mobile replacement for this lady's spine, unfortunately.
And would be a problem for a different specialist too, right?
Yeah. Yeah.
So Matt, what do you think about this case?
Yeah, I don't think I really disagree with much. I mean, my approach would be staging it, doing A-lifts first, certainly at 5'1" for the fusion advantage and the support. And I would try to sneak a little bit higher, even if I just put a little, even if I didn't do anything structural and just put graft in there. But yeah, and then I'd go from the back, obviously high in the thoracic spine on down. I would not be trying to spare a disc at the bottom in this case. You know, I guess the only question is, yeah, and I guess I would say I would try not to chase too hard on the coronal stuff at the risk of flattening her out or screwing up her sagittal balance. I mean, obviously she's got that deformity at her thoracolumbar junction, so you're not going to stop right around there. But I wouldn't push too hard on straightening out her coronal plane either.
Got it.
What are
you navigate this case? Oh, I'm sorry. Go, John.
Oh, go ahead. Sorry.
Do you navigate these cases, the screws?
I do not. I would not. And then did you already show some bending films, or did we do bending films?
Yeah, I don't have it, but this pretty rigid deformity.
It looks like it.
Yeah.
What are some of the strategies you use for UIV, like a soft landing or prophylaxis? Do you ever use TP hooks or cement or tethering, or just curious?
Yeah, Jonathan, I'm using sublaminar bands at the moment. Seems to do quite a good job, but for a younger patient, I would tend to use TP hooks.
That's what I've been using personally, is TP hooks. Well, Alex and Matt, what about you guys?
I'm kind of back to doing nothing. I guess I'm not totally convinced, but I'd be happy to be convinced and get back on board with something other than meticulous, right? You know, than not touching the joint and other things, but and leaving the tension band intact and all that other stuff and being real careful. But I guess I haven't been convinced of anything else yet.
Gotcha. One thing I have found interesting, I don't know if there's a paper written on this, maybe something for us to look at, but I've heard it mentioned a couple of times before. If you look at her sagittal full length X-ray, basically her thoracic spine is behind her sacrum, right? So, and that's before surgery. I wonder what's the risk of PJK in this specific patient population versus patients who are totally sagittally imbalanced, like they're totally hunched forward, right? Because when you correct them, the X-ray looks fantastic, but in some percentage of those patients where they're so sagittally imbalanced and you correct them and the thoracic spine is a little bit behind the sacrum, I feel like that particular patient is at very high risk of PJK. Those patients who are just in gross sagittal imbalance, and then you bring them back to where the thoracic spine essentially is behind the sacrum. Those patients are particularly at risk of PJK. I see almost virtually all those patients PJK. I'm wondering if there's anything associated with that, but just I would assume that this patient is at low risk just because pre-op they are within those boundaries. It's interesting.
Yeah, this kind of AIS in the adult usually are coronal problems and not sagittal problems. It's completely different in the adult spinal deformity. That's different kind of animals, and it has been published that we're using the GAP score for predicting the risk for PJK in these kind of cases. I'm not completely convinced about the utility of the GAP score, but it sounds logical that the lordosis redistribution for those specific patients will help. But I have PJKs with a perfect GAP score, and I don't have PJK with completely disproportion patients. So I don't know. What do you think, Alex?
Sorry. Hello from Switzerland. Guiroy, this is a hard case. Interesting. I don't use this GAP score. I don't do so many of these deformity surgeries. My patients are usually a lot of older, like 70 years old. I'm not heading for major surgeries in these, so I'm not really familiar to these scores.
You, Matt, are you using that?
Somewhat. I mean, I think it's somewhat useful. I think one of the equations we use for setting the lordosis based on the PI comes almost straight from the GAP calculations, saying, taking the PI times 0.6 plus 30 gets you pretty close to what kind of LL you want. I think that's right out of GAP. So using it somewhat, I guess, not 100%, but to some degree.
So as most of you proposed, we stage this patient. We did the first stage on ALIF, phase 1. And 1 week later, we go from pituitary to pelvis. We did posterior column osteotomies and this multi-rad construction. I find this multi-rad construction very useful for preventing rod fracture. It actually reduced our rates close to 0 rod fractures in the last 4 to 5 years. So we will see in the future, but I think it's a useful maneuver. And these are the full spine X-rays, the post-op. Comments, criticism.
I think it looks great. I'm glad you didn't chase the coronal stuff too hard. I think that patient's bound to do reasonably well. What those cobalt that you're using, and then do you mind telling us just about kind of the ordering of your rods and when you're going through that?
Yeah. Hey Nere, how are you? We're using 6 0 chrome cobalt rods, all the 4 of that. We tend to construct from the bottom up this patient. Her pelvic was pretty balanced, so we try to construct from there up and try to pull the spine to the rod, so we don't have a decompensation in the coronal plane in the post-op. I was very concerned about that and overcorrecting them and get the patient in a pizza position. So I tried to construct these patients this way with a very strong rod from the bottom up, and that's what we did. Nader, you want to comment that?
Hey,
You're
Alfredo, I'll have a chat.
Hey, Mike.
Yeah, look, looks nice. I mean, I think it'd be, I suppose, good to have a show of hands from people doing this work regularly as to who's gone to multi-rod constructs particularly across the lower part or the apex of the deformity, plus across the lumbosacral junction. I mean, I'm certainly, even when I don't do a PSO and when I'm doing an ALF, I still now use a 3-rod construct minimum, if not 4 for bigger curves. Always use 4 when I do a PSO or corner osteotomy. I don't know what others think about that, but look, I mean, it's early days. I've only been doing that for about 2 years now. So my belief is that I won't see the failures just yet. They're coming, but I've been lucky enough so far not to have any major failures with that tactic. Don't know what the other panelists think about that and how they're using multi-rods for these kind of big deformities.
I think Nader wants to say something. He's muted right now.
Yeah.
Yeah. Here we go.
Okay, thank you, guys.
Hey,
Great
Nader.
result, Alfredo. Excellent case. Certainly, with these. I mean, I'm not I don't claim myself to be a deformity person, but certainly, you always want to address a fractional curve at the bottom of the construct, L5S1, and as Mike alluded to, you see the disc height pretty healthy, but the issues are in the facets usually if the disc height is healthy, because that's where the stress is. But so certainly with these long constructs, you got to always get down to the pelvis. A beautiful result, well balanced, looks really good.
And she's doing good. So far, so good. We're gonna move to the next case. Sounds good. Pues, this is the single case for discussion. It's a 40-year-old lady. She's an attorney-in-law, so that's an independent risk factor for complications, from at least in my practice. That consulted to us in a different place with this MRI in 2018, with some neck pain and some C6 paresthesias in the right arm. So her surgeon decided to do a 3-level ACDF, but unfortunately she woke up with a severe left hemiparesis, dysphonia, and some swallowing issues. So she was discharged to a rehab facility. And 6 months later, she recovered some of her neurological deficit with some residual spasticity and bladder issues. But well, this study just began, and she started with some Lermite sign when flexing her neck. So her surgeons decided to do a C3 to C6 laminectomy without fusion. And so when she came to us, looks like this. She developed a post-laminectomy kyphosis as expected. And this is their x-rays, C2, C7 lordosis, 4, and the T1 slope was 18. So the mismatch was 13. But she had a focal kyphosis between C4 and C7 of 33 degrees. Fortunately, it was very flexible and in the x-rays, and reduced to 20 degrees of lordosis in extension films. So This is the CAT scan with non-union and all the ACDF, and this collapse and subsidence in the C5 body, with the body of C6 and C6 pushing into the canal. So she's in a severe back and neck pain. She can work, she can read, she can drive, she can do anything. Her ODI is 61, the neck disability 84, and the BIS neck is 10/10. She's on the morphine, pregabalin, Tylenol, ibuprofen, cannabis, I don't know, everything. So this is the case for Nader. I know he'll have these kind of crazy things, right? So how do you approach this patient? Remember the swallowing issues, the dysphonia, so she was very concerned about that. She was very afraid of losing her voice again. So are you ordered specific studies or tests to do posterior, do anterior, you go back and forth? How to deal with both the anterior, the non-union and the deformity, where to stop on the upper level and the lower level. What are your targets when you're doing the surgery, the T1 slope and the lordosis mismatch, the balance, the fusion? Well, it's all yours.
She's not really an attorney though, right?
No, she is.
I think I'll make mine short. I think I'd be inclined, given how flexible she looks on those FlexX films, and I think I'd be inclined to go posterior first, C2 to T2, and depending on what the anterior issues are with her voice, I might have missed some of that. Certainly looks like she's going to be. Certainly looks like she'll be. Her cord's going to continue to be draped over this subaxial segment here of non-union stuff. It'd be nice to do something in the front, but boy, I think I'd go posterior first, establish similar doses, C2 to T2, and probably let her recover, see how she does, maybe get a scan, see where we are. I don't know, I'd hate to go back in the front, even though it looks like you might need to. Bad, unfortunate for her.
Yeah, I totally agree with you, Matt. I think it sounds like most of her problem is pseudoarthrosis and then the lack of posterior support and fusion. Essentially, she had a laminectomy without a fusion. I totally agree with you, Matt. It's exactly what I would do: C2 to T2, instrumentation and fusion. I don't think I would approach her anteriorly, given the fact that she has already a laryngeal nerve palsy and some element of it was dysphonia, not dysphagia, right?
Both.
It's both. Okay. I would be very, 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 very loath to do anything anterior. I think I agree. She's very, very flexible on the flex X. I think I'll just do this all posteriorly. And then I would supplement with, if there's any concern about her fusing, because she had a non-union before either, with I would use BMP in the posterior cervical spine. I know some people wouldn't do that, so then I would consider using like iliac crest or some sort of really make sure she's very well decorticated and put some excellent bone down in that area.
Good.
Yeah.
Good.
Alfredo, I have a question. She is 40 years old, and I think every attempt to help her failed in the past. If I can put it all together, I would respect the patients well, not to go into troubles from the approach, from anterior approach. So I would tend to do everything posterior. But if this would be an implant-associated infection, if this is a low-grade infection, we are running into big troubles because we won't heal it from posterior without debridement. Do you have some findings suggesting it's not an infection, it's not a low-grade infection anteriorly?
Yeah, that's a very good question. The lab was completely normal, so we suspect that it's not an infection. We get a spec CT of this patient, but it's difficult to interpret that because non-union will be brightened in the SPECT CT as an infection. So we have the same question and the same concern that you had.
So I would do it posterior only.
Yeah.
Yeah, I agree with the consensus. Certainly, you wanna make it better, but not perfect. Obviously, due to the concerns of dysphagia and dysphonia and the bad experience he had before, you know, we're assuming this is a pseudoarthrosis and kyphosis, and you want to lock her in the best position possible when you position her. And I think her CSVA is not going to be that bad. So yeah, I agree. I would go posterior only, C3 to T2 or C2 to T2. And then you hope that the bone will remodel and then heal. She doesn't have, you know, her myelopathy is static. You know, cord signal change, contusion. That's not going to get better. I'm going to try to help her out with, you know, the goal of the operation is improvement of realignment, bone healing, and stabilization. Better, not perfect.
Yeah, sure. Matt?
May I just ask the audience and everybody, if you do, after the ACDF, the 3-level ACDF, if you do any posterior approach, now it was just decompression only, would anybody suggest that this would be something should be repeated, or do you always put in screws and fix it from posterior too? Because I think this is something I always tell, never leave this just decompressed, always add a fusion to prevent for the damage. Do you have similar cases where decompression only helped? Was it successful in multi-level laminectomy? Has anybody experienced that it could be possible, it could work?
Alex, they often end in disaster like this. I think, you know, that was with hindsight, not a great decision by the surgical team at the time. You know, because if this is a non-union to begin with, or there was a hint of it, and I think the you know, the injury and the instability following that is a hint that maybe these cages aren't enough in a 3-level setting. They should have put implants in the back, and if you'd gone and done that, they may well have saved a few levels now. So I think that's a careful decision, but it's probably a good learning point. We can learn from this this error here and what's happened to this patient. Yeah, absolutely agree with you. I would definitely go to the back here and put in implants at the time. I reckon they might have saved at least 2-3 discs with that. Yeah. Just talking fixation from the back, I'm interested. You know, this patient's had a posterior laminectomy. Alfredo, how were the lateral masses in terms of bony landmarks? And personally, for this type of case, I would definitely use navigation posteriorly because I'm lucky enough to have it, but also because post-laminectomy situation, sometimes they've gone quite wide. The lateral mass anatomy is not great. They look reasonable here on that CT scan, but it's something you have to consider. And certainly, if you're not going to go back to the front, I think that's entirely a reasonable option. Using pedicle screws as well here could be a big advantage in terms of the overall stability of the construct. And the other little trick I do every now and again is use what I call the in-rigger, which is C7 to C2 interlaminar screws, and you join them up as well. So that's all. They're all good things.
Yeah. Any tip for positioning this patient for getting enough lordosis to get a good alignment? Nader?
I usually use the Mayfield head holder, a 3-point beam Mayfield head, and I distract them a little bit and pull them up. That's what I suggest. That's what I usually use or do. And with that, you know, not great. Sometimes you lose lordosis if you're starting off with a lordotic spine, but I bet you she'll straighten up better and she'll have a reasonable alignment. yeah, I wouldn't put it in traction or anything like that. I would just use the Mayfield head holder, and distract, like pull her neck up, cranial, and then dorsal.
Yeah, I agree. I would use the
Use
Mayfield
any-
as well.
yeah.
I know. I mean, you could try. I would use the Mayfield. I think it's easier to get that lordosis. You could obviously do, bivector traction with the Gardner Wells, which some of the folks that are really slick with it are good. I think it's a little harder in my hands to get it where I want it.
Use intraoperative films to get some target in the EX films, for example, C1 slope, C2 slope, or you measure lordosis intraoperative, or it's just a feeling with the position.
I would rely a lot on all the preoperative imaging and have a standing film and look at where we want her to be, and then try to get whatever landmarks are easiest to match that in the OR.
Good. So we don't have navigation, so we're gonna do this at the old fashioned. So we thought the same as you. I'm very concerned of doing anterior in this lady. So we did all posterior, C2 to T2. I thought that it was my only shot for this patient, so I add an extra rod with transland in C2 and T1. I don't know, psychologically, I think it's stronger, and I can use some cantilever maneuver from C2, pull down, and to get lordosis with the screw T1. This is the AP view.
Beautiful.
And this is the CAT scan. And she's you can see the C2 slope, how it's get horizontal to the floor, and get a good lordosis restoration from 6 in the pre-op to 32 in the post. But and now what? Do I go anterior or should I wait and see? I think we talk about this, right? Mike, give a shot. Wait and see.
Alfredo, wait. You've done a really
now.
nice job there, mate. You've done a nice job. I would wait and see. Watch them closely. I think this sort of patient, although they're young, you justify a CT scan at 3 months and at 6 months just to make sure that there's no early loosening, that bone is forming where you want it to form. Look, I mean, if it's, Alexander made a great point before about infection. If there's no infection there, my experience with non-union, with titanium-based devices, is that they go on to fuse quite nicely once you stabilize them. There's an instability problem there. The PEEK devices, they can cause a few more issues because you get this fibrous, microscopic sort of fibrous margin across all the PEEK area there. But I have a feeling that this should go on to fuse really nicely, and you've done a great job. So definitely wait and see. Personally, CT and X-ray at 3 and 6 months, and watch and wait and pray if you believe in that.
What do you think about the extra rod? Do you think
yeah,
it's
that's
useful,
what absolutely. I mean, that's what I call the in-rigger, Alfredo. The in-rigger. It's the opposite of an outrigger. And you can do that C2 to C7. So whether you got nav or not, and before I had nav, C2 laminar screws, you could do as an adjunct here, and you can actually run an extra 2 rods from C2 to C7 if you want to, that stay below the tips of the spinous process, just by doing interlaminar screws at those two levels. Or you could do T1, like I think you have there. 3.5 mil rods, which is the standard for this. And I think some systems are now going 4 to 4.5, which is good. But 3.5 rods are not that strong, and not for a big deformity. I know the bones are smaller, but you still got the weight of the head there. And I really prefer, if you're going with 3.5, a multi-rod construct as you've done, Or, I mean, if you're doing pedicle screws and you've got a system that takes 4 to 4.5, you might be okay. But yeah, I think relying on 3.5 rods over a long segment is also a recipe for disaster.
Yeah.
Hey,
These are 4 crown collar robots. Yeah.
These are 4 mil. Nice.
Yeah.
How did she do with the
Matt.
surgery? And I mean, that looks beautiful. She got 2 really poor surgeries, and that looks great. Was that with and one really good one? Is that with a Mayfield, and any trouble moving her introp, any trouble with signals and stuff like that?
No, fortunately no. We use a horse head support, and I use I bend the rod to the position I want. I don't use much Mayfield. I had a lot of pre-lordotic patients with the head anterior to the sternum with the Mayfield. So I don't know why. Maybe I don't pull up as needed, but so I abandoned Mayfield because of my bad results, and I use old-fashioned head holders.
Sorry, you're saying Gardner Well?
Alfredo.
Horse. Yeah.
Alfredo, may I ask you, what did you do with the facet joints, with the cervical facet joints? Did you resect something, and did you add some compression?
I do
or
not.
Was it just in situ?
Yeah, well, just in situ, I just try to respect the facets as much as possible to use as a bed graft. We don't have BMP, so I use iliac graft. But I try to do posterior column osteotomies if I don't need to try to respect that. Fortunately, it was just positioning, and we don't have signal changes. All went smoothly. But I was very afraid before this case. Now it's a happy case, but it could be a disaster.
So the first lateral image after you positioned the patient, you knew exactly that the low doses was restored?
Yeah, we used to measure that intraoperatively. I tried to do the C2 to C7 angle to see if I going where my target was. And was pretty easy to correct that. I found that in these cases, the extension films said as what you're gonna get in the operating room. So if you get 20 lordosis restoration in the extension film, okay, that's what you're gonna get in the OR. No more than that, no less. You try to push to that. The patient did that position asymptomatically. So if I go to 20 degrees in the OR, I'm pretty sure that I can get that lordosis restoration in the post-op. Should I answer?
Yes, thank you very much.
So she's now 6 months post-op. She's completely free of medication, very happy. So we talk about see the next CT scan and see if she's doing this good. I probably won't go anterior. I try to avoid that. So that's the end of this case. We'll move to the last case.
Hey, can I ask a quick question?
Sure.
The in-rigger, as Mike called it, is everybody doing that? I'm not doing that. Is everyone doing that? Is everyone convinced this is?
Just for kyphosis deformities, not for degenerative.
But yeah, no, that's what I mean though. For anything like that, where you're changing the alignment, is everyone kind of using something like that?
Matt, I've been doing it when I've only got the 3.5 rod systems, because I feel the 3.5s are really weak. I think if I had a 4 or 4.5 rod like some of the newer systems are having, and I may not do it, particularly if I was worried about prominence in a skinny patient. But it's a pretty simple thing to do. We've got a question on the chat. Is it from translaminar fixation? And it is. So they're just those simple interlaminar screws, and it's an additional rod going across there. I started doing it when I was doing a tricky cervical deformity, and I was a bit worried about everything moving around because there wasn't much anterior support in that case. And I thought, when we're in the lump, when we're doing a PSO, you get that additional rod in there. But in the cervical spine, it's right in your way when you're resecting out those facet joints. So I thought, oh, okay, if we leave this rod proud, I might start. And then I thought, well, at the end of the case, it wasn't any more proud than the patient's spinous process tip there was anyway, and just left it in. And that was the first case I did about 5 years ago when I did it. But yeah, I don't think it's mandatory. I think with some of the newer systems and bigger rods and cobalt chrome, you'll probably get away without it a lot more. But a 3.5 titanium rod, which was my working tool in the posterior neck for a long time, I don't think is adequate for big deformity or effectively an unstable spine like this.
Yeah, I agree. So this is the last case of today. It's a boy, 14 years old, that presented to us with bilateral sciatic pain, low back pain. He had 4 months of L5 bilateral pain, and it's get worse when track flexion and walking. His hips has some flexion contracture, but neurologically he was intact. He played rugby, and these are the full spine X-rays that show the high-grade dysplastic L5 S1 spondy. He had some bending forward posture with the SBA fallen over the femoral heads. He had a high pelvic incidence of 72 with a lumbar lordosis of 63. But on the focal X-rays, we can see a lumbosacral kyphosis, 73 degrees, and the inclination of L5 was over 100. So the flexion extension films doesn't show much movement, and the MRI had the classic bilateral foraminal stenosis with some reduction of the sleep when compared with the X-rays, the standing images. The actual MRI showed a very good window for an A-leaf at the L5S1, and the CAT scan showed bilateral spondylolysis. So this is the guy, 14 years old boy, high-grade spondy, lumbosacral kyphosis. So my questions are, do we classify this as a type 5 or a type 6 in the label classification? We do reduction of the sleep or the lumbosacral kyphosis, or do an in situ fusion. Staging, posterior, anterior, posterior, all posterior, or whatever. Interbody is needed, L5S1 or not. Interbody is needed if we go upper, for example, L4, L5, and L5S1. Will be your lower instrumented fusion of the sacrum of the pelvis. You go to L4, you do just L5S1. And what about neuromonitoring for the L5 nerves? You want to catch this, Matt?
I certainly don't have a lot of experience. I'll defer to the guys that do, but I guess the things I would say is that I think in this case, I'd worry a little bit about too much reduction. Looked like, and the other thing is I think you mentioned where we're fixing to. I mean, I would definitely be making sure we have good fixation. In this case, I'd be fixing to the pelvis with a high grade like this either way.
Mike?
Yeah, these are, I think these are the most challenging cases because, there's a lot of stress, the lumbosacral junction. It's really hard to get the balance right. Matt's correct about, how much you reduce. Yeah, to me, you want to get these patients back to a grade 1 or low grade 2. You don't need to go for broke on the reduction. But the most important thing is to maintain or restore the segmental kyphosis at that level. So I focus more on that than on complete reduction. But the other thing, and early in my career, I certainly failed in this a couple of times on cases like this, is when you're choosing your levels, most of us would go L4 to pelvis here, but you've got to keep that compensatory hyperlordosis that they often get at L4-5. So you really want to look at 4-5 and lock that segment in with a real lordotic compression rod and take it down the facet a bit if you do this from the back. I mean, just taking a step back, my plan for this patient, because they're going to progress and they've got some flexibility now, would be to get on and do this surgery. I would go L4 to pelvis posteriorly with pedicle screws, L4, L5, S1, and probably S2AI. I haven't done bedrock in kids yet, but I probably should be. But then again, for the kids, I haven't seen them loosen up their S2AI screws very often with this type of surgery. At 4-5, I really take the facet down and try to squeeze that together to maintain the lordosis there. At 5S1, wide laminectomy, come out over the roots and then get into the disc and just really do a bit of a sacral dome osteotomy. Look, some people then would put a little T-lift cage in there. I am not against that at all. I think that's a really good option. But personally, I do prefer anterior column support. And so what I do is I reduce these from the back and using 2 cobalt chrome rods, you lock in L4-5 and then you reduce L5 down to your S1 and S2AI screws with cantilever type reduction with neuromonitoring on the L5 roots. And you go really slow, use your reduction towels and just go really slow. And then I lock that all in and then basically look at what we've got. And if the alignment's good, I consider coming back to do an ALIF later on at 5-1 to give that interbody support. And if the angle is not appropriate, at least you can get to the 5 body and do a Bowman or reverse Bowman type technique with a cage threaded from the 5 body into the sacrum. And I think this just adds additional support. I've got burnt by leaving these all from the back with a small T-lift cage. Patients look great for 2 years. And at the 2-year anniversary, it's happened twice, they come back with a rod fraction at L5S1. And I managed to salvage both those posteriorly with some BMP and then going and adding an anterior support. But you can look at these for many months or years afterwards and think you've done a great job and something's brewing there. And it's never a nice revision.
Absolutely. Yeah, you're spoiling me. And any concerns about ALIF in young boys about retrograde ejaculation?
Yeah, look, I mean,
that was my concern. If this is a lady, that's my plan. Posterior, anterior. I don't have any doubt about that. But in a boy, I had some restriction about it. What do you think about that?
The rates reported in the literature are so variable, and I'm knocking on wood because I just don't see it that often. But maybe I'm not looking hard enough or asking the right questions. I suppose from a reproductive perspective, though, my colleagues in that area tell me that there are lots more ways around it. I mean, when I first started looking at ALIF, we were getting young men having this type of procedure to do sperm banking and that sort of thing, and that's all not necessary now. They can get around any reproductive issues down the track. I mean, it's not a pleasant complication. So I as I said, I personally am not against the T-lift altogether, and I've seen some great results doing T-lifts on this kind of case. But I like the bigger footprint of the anterior cages here, and or a Bowman technique. And look, it's a risk that I'm prepared to take with informed consent with the patient, but certainly appreciate that others may not want to go that way. The reported rate is 1% or less, so it's pretty low. Minimizing diathermy on the front of the disc, and particularly on the front of the pre-sacral area, is helpful. And I think if you've done most of the work from the back of the spine here, you can really minimize your dissection on the front of the sacrum, and I think that's likely to help with that potential issue as well.
Yeah, so the other question I have is, these high pelvic incidence guys are pretty difficult to approach. The angle of attack for the L5-1 disc is very difficult. So how do you position these guys? Or after a reaction from the posterior approach, you get a better access?
Yeah, that's why I do the posterior first in this, and really also releasing the roots at the back helps, I think, with your potential problems with L5 nerve root stretch. I don't know what others have found when they do these cases, but I find that, you know, during surgery, the neuromonitoring is usually pretty good, particularly if you go gently and take your time. And often these patients actually come up with a palsy several days after you've done this surgery. I don't know if any other paddlists have had that unfortunate experience. It's not pleasant. Just the way around it, I've found, is to just, whenever the patient's lying, keep the hips flexed, knees flexed, keep the tension off the nerve. Usually it comes good.
Yeah, Mike, thank you. You have done a brilliant summary of the biomechanics. I would do definitely the same. I would try to do the same. My question to you would be sacral osteotomy, sacral dome osteotomy. Alfredo, can you show us the nice dome of the sacrum, perhaps on MRI? Yeah. It's sometimes it's easier from posterior to do a dome osteotomy for a better shape for your cage, whether TLIF or ALIF later. In this case, maybe it's not so important, but this is a topic I would love to add for discussion: sacral dome osteotomy.
Yeah, Alexander, I release the disc there, and I do get the osteotome in and shave it down. I think that's, you know, you get to that better bone there as well for fusion. You know, they're often got really hard bone across that sacral dome. And yeah, by getting into that area, you're sort of freshening it up, ready for it to fuse. And probably some of the cases I had where the TLIF or interbody work there, there was a late rod breakage, which is a pseudarthrosis. You know, perhaps I didn't do enough work on that sacral dome in hindsight on those cases. So it's a really good point you raise. I think that's something we've, I think if you're doing this all from the back, it's absolutely essential to do some good work on that sacrum. And yeah, I know we don't all have access to navigation, but it can be pretty scary sticking the osteotome through there. And this is where, yeah, actually having navigation can be invaluable, because you can do quite a wide sacral dome resection from the back.
So I will move forward because we have scarce time. We did all from posterior, L4 to pelvis. We tend to lock L4 as one, make some distraction and neuromonitoring, work on the disc space, do the dome osteotomy, always having direct localization of at the L5 nerve. Once we got the interbody placed, without the reduction of the lumbosacral kyphosis, we don't want to reduce the sleep, but usually when you reduce the lumbosacral kyphosis, the sleep reduced by itself. So that wasn't our target, but it reduced by itself. And then with some cantilever and the rod in the L4 lock, final raster reduction, you can see the lumbosacral kyphosis get better, and so the lumbar inclination of L5. These are the post-op full spine X-ray. This guy is 4 or 5 years old post-op. So far, so good. She didn't break the rod yet, and you can see the dome osteotomy and the interbody in the disc space. So another concern in this patient is hip flexion in the post-op. The patient looks very bad in the post-op. It looked bent forward, and you see, oh, what I did, and the patient get in the right position by itself with some rehab. Do you have any experience about that, Mike?
I mean, the hip flexion is probably a bit of a neuroprotective mechanism for the L5 roots are a bit stretched, and they get that neural tension. with the reduction, the partial reduction here. I mean, that is an outstanding result. It just looks great. You can see the bone growth through the cage. L4 has been, not quite horizontalized, but it's a high PI patient, so it doesn't have to be. It looks great. And I think, it's an outstanding result. But it's probably, the patient was probably leaning forward because of that tension that you get on the 5 roots. And if your monitoring was fine in surgery, it still can happen late. 2 to 4 days after, I find to be the peak time for them to get some L5 issues. So that's a really nice case, Alfredo. It's good work.
Thanks. Any other comments, man? Nader, Alex?
Beautiful result, Alfredo. This is excellent. And I agree. I would have gone L4 to pelvis. I tried to make the L4 end plate as horizontal as possible intraoperatively, and careful reduction. I mean, this is an excellent, beautiful case. You got perfect reduction.
Yeah, I got nothing. That's a great case, great result. All those were great cases. Thanks for showing those. Those were perfect.
Yeah, awesome cases, Alfredo. Thank you so much. This was a fantastic discussion. Great cases. I feel like we would talk for hours on each case individually. Awesome results on all of them. So I thank everybody for joining us tonight at Virtual Global Spine. I look forward to seeing you all next week. Take care.